Hello, everyone, and welcome to the Psychology of Resilience and the Associations with Chronic Pain webinar. We're glad you're here with us today. My name is Tanya Hyde, and I'll be moderating the webinar today. I'm the project manager with the Canadian Institute for the Relief of Pain and Disability, and this webinar is co-sponsored by CIRPD, ourselves, and Pain BC in collaboration with the Canadian Pain Coalition. It's made possible through the support of the Community Gaming Grant Program through the BC government, as well as through donations and memberships to our organization. As I mentioned, my name is Tanya, and I'm moderating the webinar and handling the Q&A session today. And our presenter is Dr. Toby Newton-John. Dr. Newton-John is a practicing clinical psychologist at Northern Private Pain Centre in Sydney, as well as a senior lecturer in clinical psychology at the University of Technology in Sydney. He has published over 40 journal articles, book chapters, and reviews on the psychology of pain, and is an assistant editor of Australian Psychologist. His research interests are in the social dimensions of chronic pain, particularly the impact of pain on interpersonal relationships. So I will hand it over to you now, Dr. Newton-John.
Thank you very much, Tanya, and good afternoon to everybody over there. It's a fairly chilly Sydney morning over here, but thank you very much for the opportunity to well, I guess talk at you for the first part, and hopefully we'll have some time at the end for some questions and a bit more interaction. But I've got the next 45 minutes or so to share with you some thoughts on pain and on chronic pain, and then this concept of resilience, which is quite a new area for chronic pain researchers. It's a concept's been around for quite some time, but it's only fairly recently that research in the area of chronic pain and the psychology or the psychological adjustment to chronic pain has started to look at the concept of resilience and to see whether resilience as a notion has something to offer us in understanding how folks with persistent pain cope and adapt to their physical health difficulties over time. So this is what I'm going to hope to get through in our time, just to contextualize all of this in terms of our current understandings of pain and how pain neurobiology is starting to inform the experience of folks with ongoing discomfort that apparently doesn't have any lesion identifiable. Spend a bit of time looking at resilience and how it's defined and how it's been measured. Then I guess the crux of this is trying to put those two things together. And so how has some of this early research in the field of chronic pain resilience informed our understanding of managing chronic pain? And then if we have a bit of time, I guess the sort of the important question here is resilience something that you just have, or is it something that you can learn to become in relation to any ongoing adversity, but I guess particularly in relation to chronic pain is what we're talking about today. So that's really my hope to be able to cover these sort of areas over the next period of time. So in terms of the starting point in anything to do with pain, we need to just orientate ourselves to this definition, which really gets to the crux of pain as a biopsychosocial phenomenon. The notion that pain is both an unpleasant sensory and emotional experience is critical in understanding that to experience pain requires a conscious brain, and if the brain is conscious, then emotional experience, and as we'll see a little bit later on, a whole lot of other psychological phenomena are relevant to how we process pain and how we experience it. The definition is also very useful in terms of outlining that actual tissue damage but even potential tissue damage or the description of tissue damage is what's necessary. Effectively, pain is what people say they have, and we're hopefully moving beyond sort of 18th century when this drawing was done, of just thinking about pain as only the result of what we can see in terms of identifiable organic evidence, and that pain, we now understand, is a far more complex problem than just what one can see on an X-ray. Now, there's a lot of it about. General epidemiological studies suggest that most people in the Western world will have back pain of some significance for at least a week's duration at some point in their life. So, in one sense, it's abnormal to not have back pain at some point in your life. So, if you think about it in those terms around, spinal pain as a phenomenon is actually the norm, certainly throughout the Western world. In terms of the prevalence, these data are from the state that I'm in Australia, here in New South Wales, but they're pretty consistent across the Western world. And the chronic pain, as we'll look at the definition in a little bit, but chronic pain is about 20% of adults between 18 and 65, and that rises to about 1 in 3 when you're 65 or over. So persistent pain is, again, an incredibly common phenomenon throughout adult lifespan. It always costs a lot, and these are local data from Australia in terms of treatment and lost productivity, but some research from a couple of years ago that came out of Sydney here, which is, I think, particularly poignant, is that 40% of folks who said that they had retired before they were ready to nominated that back pain and or arthritic pain was the predominant reason for them leaving work early. 40%. It's a huge proportion of people who would otherwise be wanting to stay at work and maintain their work activity, stop work early because of pain problems. And that's important for a host of reasons, but interestingly, it's important in relation to resilience and what we're talking about today, because work and work engagement and social connectedness are actually quite important components of resilience, as we'll see. So that's, I think, something that we're going to see more and more of over the coming years is the application of pain treatments to enable people to remain work active. Given all those figures, though, about prevalence and disability related to pain and so on, it's important to remember that if generally speaking, around 20% of the population have persistent pain, it's not 20% of people who are terribly disabled by it. In fact, it's a smaller proportion of people whose pain becomes such a problem that they're unable to function, remain at work, look after their children, so on and so on. There's a much smaller proportion, thankfully, where their pain becomes disabling, and that's quite relevant for the concept of resilience as well. So again, just to contextualize this so that we're all on the same page, acute pain, the pain that everybody experiences, or virtually everybody experiences, this congenital analgesic disorder where people don't have a pain perception system, but the vast majority of us have some sort of pain experience frequently throughout our lives, and the majority of those all resolve either just through natural healing or some application of some sort of treatment. But the chronic form, where the pain doesn't resolve and persists after the usually now defined as 3-month mark, is where we're talking about today. So the pain goes beyond the expected healing time. Sometimes chronic pain is defined as pain which has no survival value to the organism anymore. It's not serving its purpose as a warning system to take action or protective measures in any way. It just continues and continues and continues, often for many years. And what we'll look at a little bit is the understanding now that chronic pain is associated with not obvious but increasingly identifiable changes to the way the central nervous system works. And we have these couple of sort of subcategories, if you like, the subacute pain, so the kind of window of opportunity between 4 weeks and 12 weeks where the central nervous system may not have undergone all the changes that seem to happen with chronic pain. There's potentially an opportunity to intervene more effectively. And then there are chronic recurring pains like migraine headaches or period pains where people have pain-free intervals, but then an ongoing recurring pain episode. You can see that these definitions are mainly time-based in terms of the duration of pain, but as we'll see, there's more and more evidence that there are different mechanisms at play which relate to how long the pain system is activated, if you like, and that does make a difference in terms of treatment and in terms of outcome. So in terms of the understanding of the neurobiology of pain, this diagram here may be familiar to folks. It's the René Descartes' initial early theory of pain, specificity theory in this case, where Descartes said, pain is the result of some sort of noxious stimulus, like a fire, and then somehow pain travels along some sort of, what he called it, a neural tube, so some sort of transmission system, and then reaches the brain, and that's what our understanding of pain is. That was I think 1664 that theory was published from memory, and so over here is the contemporary understanding of the neurobiology of acute pain, and you can see that it's a bit fancier, and there's some terms on here. But essentially, it's a pretty similar idea that some sort of noxious stimulus like heat or chemical irritation or pressure or something like that is applied or occurs to the periphery. It's transduced, so it's the energy is transferred from, this case, heat into electrochemical signaling, moves along the peripheral nerves to the spinal cord. Modulation occurs in the spinal cord, and we can look at that a bit more later on. And then it's projected to the cortex, and not actually as depicted here to one center, but actually numerous centers in the cortex. And when it reaches the cortex in a conscious brain, that's where we have pain and the perception of pain. So these two sort of models are really quite similar in terms of how we understand the basic transmission of pain. But as everybody knows, of course, it's possible to experience or to have the phenomenon where there is some normally noxious stimulus being applied, but the individual doesn't report any pain experience. So in this case, we have a similar kind of transduction, a heat stimulus being applied to the soles of the feet, but those folks who go to some exotic Pacific island and learn how to do firewalking don't report any particular pain afterwards. And this, of course, is something in lots of religious ceremonies in different cultures. There are examples where there is undoubted tissue damage occurring. This is a crop blessing ceremony in Sri Lanka, where a male from the village is chosen. It's a great honor, and the male moves between the different villages in an area, blessing the crops for the new harvest. And this is something, again, where there's no report of pain, and yet there's very clearly pretty significant tissue damage going on. So that original theory of pain and the more modern version that I showed you earlier on can't really account for phenomena like this. And there's, of course, legion, athletes being injured whilst playing sport, and soldiers on battlefields, and lots of less dramatic versions where we in fact injure ourselves, we don't experience any particular pain. And to try and make sense of this, neurobiology in pain has identified since the gate control theory, Melzack and Wall's gate control theory of 1965, that in fact our brains don't just passively receive information about our bodies in this ascending way, but actually there's a descending control system or a descending inhibitory system where our brains have the capacity to modulate, to vary, to block or to amplify the ascending information coming up into the system. So if the conditions are right, and we'll look at this just in a bit, the brain is capable of inhibiting the afferent activity coming up the spinal cord, so that the experience of pain is diminished or even on occasion completely filtered out at the level of the spinal cord down here. So this has been a very significant, hugely significant, in fact, development in the understanding of pain from those initial models. So in its entirety, it looks more like this. So this is where we are currently with understanding pain experience, again in a conscious brain. So we have nociceptive input. We have noxious input coming into the spinal cord from injury, from disease, from chemical irritation, whatever it happens to be. But there's also a number of factors, both chemically and psychologically or psychosocially, which impact on how much that pain experience actually, the level that the individual ends up perceiving. So mood has a very strong effect on pain in terms of the more anxious we are, the degree to which we think in alarmist terms about pain, which is this catastrophizing concept, which Michael Sullivan, who's a Canadian pain psychologist, has been the world pioneer in understanding catastrophizing in relation to chronic pain. There are phenomena like what the individual expects to occur, expectations around pain itself, around treatment, around what's anticipated to be the result of a movement or an action or so on, which all influence pain experience. And then cognitions, or in effect the way the individual thinks, where their attention goes, the degree to which they are able to distract their focus from the body onto other external activities and so on. So it looks now a much more complex model than just that straightforward idea that pain is the result of transmitting information from the periphery up to the brain. There's a whole bunch of other influential variables that determine how much pain we have. And it does then make a great deal of sense as to why two individuals can have apparently the same pain experience, the same injury, the same treatment, the same noxious experience, but their experience of pain is very different one to the other. And it also helps to explain why individually the way we experience pain isn't the same every day, every time, because these factors are varying day to day, week to week, sometimes hour by hour they're varying. So pain experience is also a very variable phenomenon. So we know a bit about how these pain models work from an acute pain sense. I just wanted to touch briefly on where the thinking is around chronic pain, which again may be familiar to you, but if it's not, it's important, I think, just to touch on this, because this is where, again, from a psychological point of view, really enormous strides have been made and will continue to be made to effectively, in many cases, validate people's experience of pain. In general terms, where we are now in understanding chronic pain is that there is a series of changes that occur in the central nervous system that explain ongoing pain experience when the initial injury has healed, or at least as far as we can determine that it's healed, or where there's no particular structural abnormality detected. It turns out that both in many of the animal studies, but also in lots of human experimental work, that our nervous system, our central nervous system, changes and adapts to pain over time, and those changes and adaptations have the unfortunate consequence of maintaining the pain system, if you like, stuck in the on position. So instead of the pain system switching off when the lesion is healed or when the noxious stimulation has been removed, for reasons that are still not entirely clear, but there's 7 to 10%, or sorry, 20% which have chronic pain of the population experience alterations in brain chemistry. There's a change in the architecture of the brain in terms of decreases in some nerve cell distribution in the cortex. Nerve tracts themselves alter their function, and the way the brain talks to itself can change over time, in combination with a number of different behavioral responses, which are, if you like, often quite normal reactions to a very abnormal situation, which is having pain every day 24/7, that we now understand that with time, chronic pain is really a change in the central transmission of pain messaging. It's not about necessarily detecting the structural problem. It's about understanding how pain is experienced within the central nervous system and how it can come, if you like, to have a life of its own. So there's a sort of movement of thinking about pain as a disease in its own right, because it has its own self-perpetuating loops that occur not just in humans, as I say, but in animal studies as well. And this all links to the idea of neuroplasticity, which is the general concept that our central nervous system is capable of changing and adapting itself depending upon the demands put upon it. So in terms of treating all of this, acute pain, either the body heals, and bodies are generally very good at healing themselves, or we apply some sort of intervention, but overwhelmingly acute pain resolves, thank goodness. So most of us have many, many acute pain episodes during our lifetimes, from when you fall over as a child to sporting injuries, wisdom teeth, having babies, having surgeries and so on. And the vast majority of those pain episodes resolve. Unfortunately, if a chronic pain state occurs and the central nervous system adapts itself in the ways I've been talking about, there are many different kinds of treatment possible, but the outcomes are actually pretty disappointing. So I just want to share with you some a meta-analysis from a couple of years back now, but it's a very comprehensive look at 76 different trials looking at 34 different treatments for pain, from mainstream analgesic treatment to invasive radiofrequency denervation studies to massage to psychological therapies and so on. So a wide range of different treatment approaches to chronic pain. And the basic conclusion of the study is that all of these treatments had minimal effects on long-term pain relief. And basically what this research said was that 85% of these studies reported a reduction in pain of 20% or less. So put the other way around, only 15% of these studies reported a benefit or a reduction in pain of 20% or more. And on a sort of the normal numerical rating scale, 0 to 10, which is typically what people are asked when they see their doctor or the health professional about, what's the pain like today out of 10? 85% of these studies didn't do better than changing it from 8 out of 10 to 6 out of 10. It also is emerging that medications, whilst we thought in the short term were probably fairly safe, again, that's now being somewhat questioned, particularly around opioids and the concerns that opioids are possibly causing significant brain architecture change as well as the normal side effects that we understand. So it's looking, overall, we need to really work a bit harder on interventions for chronic pain because it's a pretty gloomy picture. In terms of looking at the concept of resilience and why it's such an important notion, I think, in our understanding of chronic pain, is looking at a typical kind of trajectory for somebody whose pain doesn't go away, it doesn't resolve, and what their life is like in a sort of longer term sense. So chronic pain is usually associated with reduced activity because movement tends to hurt, particularly for musculoskeletal pain. If you move, it hurts more, so people naturally enough move less. There can understandably be quite a degree of anxiety about what is wrong and whether things have been missed, and degree of frustration comes along with most people with chronic pain are very active about trying to get their pain resolved. So they see lots of practitioners and they try lots of treatments, but because it's chronic, and as we've seen, the data are pretty poor in terms of relieving chronic pain, that there's an inherent disappointment factor going on here. If you go to a doctor with pain, you'll come out with a prescription for something, and long term, those pain-related medications have lots of associated problems which in themselves cause more problems, and then we start to get to the psychosocial interference, maintaining work, financial strain, impact on family and the spouse, and so on. So this is a very common kind of consequence of the pain. But there are secondary consequences to these consequences. So the less you move, the more you experience deconditioning, as it's called, and disuse kind of problems. Over time, it's quite normal and in one sense logical that people will feel helpless and frustrated and depressed as a result of things not resolving as they expected them to. And then combine all that with feeling drowsy, feeling bloated, feeling your attention and your memory are poor, feeling like you become kind of, your lifestyle's mapped around when you can get the next prescription and seeing the doctor and so on. There's a bunch of secondary consequences to the immediate consequences of pain. And that's what chronic pain ends up becoming, is about excessive suffering as a result of all these secondary problems. And if one consideration, I guess, of the concept of resilience is whether resilience is something about having the pain but not experiencing excessive suffering. There's maybe one way of defining that. Because as we said, remember, 20% of adults in the Western world report some form of persistent pain, but the number who actually become disabled by it, the number who become that excessive suffering group, if you like, is much smaller. So the question is possibly, are those folks who have pain but don't end up becoming significantly disabled by it, significantly distressed, are they the ones who are actually demonstrating this idea of resilience? So, what is resilience? What is this term? Well, there's a number of thoughts as to how we might define it, but just putting it into context, resilience came out of really the study of children and of youth, and looking at children who are exposed to chronic adverse conditions like poverty or losing their parents or civil wars or disasters, and tracking those children over time to look at the development as they become young adults and adults in terms of psychological disorders, looking to see whether we could find the predictors of adult mental illness from the exposure to chronically adverse conditions as a child. But interestingly, researchers found that on many occasions, despite really significant stressors as youngsters, youngsters don't always grow up to become adults with mental illness. In fact, as we'll see, it's not at all uncommon that adults become quite mentally healthy and quite well adjusted despite exposure to extremely difficult early life experience. So resilience in one sense is synonymous with ideas like positive adaptation or the general notion of adjustment, or is specifically defined in some literatures emergent resilience. So not from a one-off event, but from a chronic adverse set of conditions that resilience emerges over time. Another definition, again, from this developmental perspective, from children exposed to chronic stressors, resilience is a relatively positive psychological outcome in spite of exposure to severe risk experiences. Is another definition. In some of the work with adults and resilience, resilience is defined as actually the absence of diagnosed psychopathology. So if you don't have post-traumatic stress disorder or you don't have major depression, then by definition you must be resilient. But as some of the authors have said, it's a bit like saying if you don't have a disease, you must be healthy. And I think on any sort of closer expression, that's not an accurate portrayal of what we're trying to look at in terms of what resilience represents. And certainly, just not being sick doesn't make you healthy. So, more broadly speaking, really, resilience is usually understood as the ability to resist or to bounce back from adversity. So adversity, as we'll see, there's different kind of categories of adversity, but resilience is often thought of as exposure to adversity where there's no particular variation in functioning, or where there is a mild variation in functioning but a return to normal functioning fairly quickly. I guess the kind of corollary of this is it's something about being able to bend to a stressor without actually breaking. So in that sense, resilience isn't the same as recovery, because in recovery there's been a break, if you like. There's been sickness or illness or some significant disruption to normal function or normal psychological adjustment for a period of time. From this, then the individual recovers, so they return to normal levels. Whereas resilience, in terms of how it's defined in the literature, is much more about stability. So even though there's exposure to the stressor, there is no break in functioning. It is maintained in a fairly stable, consistent sort of way. So this slide kind of illustrates that those differences a little bit and gives some sense of what the typical trajectories or typical experiences after exposure to a traumatic event. Resilience is this line down here where there's a mild disruption to normal function, but fairly soon after normal function is resumed. And that's in a sense what resilience is trying to capture. Recovery, on the other hand, is where there's a much more significant, moderate to severe disruption in normal function, but over time there's a return to something like normal activity, normal function. And so that's the idea that recovery is really a different trajectory to resilience, because resilience has this stability to it, whereas recovery has a break in function, then a return to something like normal function. There, unfortunately, as we'll see, there are some folk who have a severe disruption to normal functioning and it doesn't return to normal levels. And then there are some folks who initially don't have a very significant disruption, but over time they effectively get worse, and there's a delayed, if you like, a delayed onset to normal functioning. So these are the problematic trajectories up here, and here are the groups who make a good response over time. So when we're talking about resilience, we're talking about resilience, in what sense? Resilience to what? Potentially traumatic events is the sort of jargon words, and the important point is that it's defined potentially traumatic, because again, in terms of defining resilience, if there's a stable response to the exposure to the stressor, then they're not actually traumatic, as the individual makes a fairly unvaried return to normal function. You can have potentially traumatic events that are single incident, time-limited events, such as a mugging, or maybe a bomb blast or a divorce or something where there's a one-off event which is time-limited, versus ongoing, unending type stressors, adversity, diseases or famine or poverty, things where there's no end point to it, it's ongoing. And these PTEs are also distinguished in terms of what are personal crises, like an illness, versus the sort of population level crises, like war, the so-called mass casualty traumas, where everybody's experiencing the same potentially traumatic event, not just the isolated individual. So it's possible to sort of break resilience down in terms of these different kinds of triggers. Now, there's actually really good news in relation to the single incident trauma. Most people in the literature, most people who are exposed to a single incident trauma demonstrate high resilience. So the stress reaction is relatively mild, it's transient, and typically people don't bump off that trajectory of normal functioning to any great degree. And just to give an example of some of this research, after the tragedy of 9/11, there was quite a lot of research came out looking at this issue of resilience and recovery and return to function. And one of the surveys of New York residents 6 months after 9/11 found that 65% of those New York residents experienced only one or none of the possible trauma symptoms over that time frame, and there's almost no depression recorded. And interestingly, they looked at proximity to the trauma, people who are actually in the World Trade Center at the time, people who are at home, sort of distance from ground zero, as it were, and that didn't have a significant effect on people's psychopathology development, if you like, after the event. So even folks who were right in the critical ground zero area, the vast majority actually showed very high resilience, and there was no great psychopathology disruption to normal functioning after that event. So the news around single incident trauma is actually really positive, and something as a surprise. And there's some literature around debriefing people after a bank hold-up or one of these single incident traumas, and questioning really whether it's all that helpful, given that most people actually cope fine without any input whatsoever. Somewhat different in terms of the ongoing mass casualty stresses like war, where the evidence is that almost everybody experiences some degree of mental health difficulty, at least initially, and over time there's about a quarter of folks who don't show a kind of resilient response or no recovery response, where there's still severe and ongoing post-traumatic stress problems at the 12-month mark. So one-off single incident traumas, we have pretty good evidence that we cope well with. When it's ongoing and it's affecting lots of people, the evidence isn't quite so good about human resilient response. And that works the same thing with depression, not just anxiety, but with depression as well. At about 25% don't show a good a good response. So if we look at what contributes to resilience then, and thinking about where this might take us in terms of understanding pain, there's a notion, there's basically 4 components to resilience. Firstly, self-esteem. So folks who have a healthy self-regard, who see themselves in reasonable light in terms of their value and their worth as human beings, tend to be more resilient. The notion of optimism, or so-called dispositional optimism, people who in some sense see the glass as half full rather than half empty, tend to be more resilient. Resilience also requires activation of coping strategies. It isn't a passive concept. It isn't something, you can't be resilient just sitting on the couch doing nothing. Resilience involves being actively engaged in things. And so having coping strategies, having techniques and methods and, if you like, tools in your toolbox to manage the stressor that you have experienced or are experiencing is also an important part of resilience. And finally, and I think this is in some ways one of the more interesting aspects of this, is that resilient people tend to have wider and stronger social networks. And the reason why I say that I think that's interesting is that I think sometimes people think of resilience as something like being tough-headed or independent or sort of impervious to feeling or something like that. And it turns out it's not that at all. People who are resilient use and lean on and access their social networks. They're not kind of stiff upper lip stand-alone types. They're people who have social integration and use that social integration to help them get through or get past or manage the kind of stressor that they're experiencing. And I think in terms of these 4 elements, these are the components to resilience being something which isn't necessarily you're either born with it or you're not. It is something that each of these 4 areas can be taught and can be learned and can be supported. And so I think it's definitely possible that resilience is something that can be sort of nurtured in somebody if they don't initially have a resilient type of response to a stressor. But when it comes to pain, we're dealing with the tricky end of the territory. Certainly with acute pain, having a traumatic injury or having an operation or being diagnosed with some sort of disease, we're looking at single incident type trauma. And as I said, the evidence there is pretty good that people on the whole show high resilience and they get through those things. But chronic pain, persistent, day in, day out, week in, week out type of pain actually fits much more with this chronic adversity model, where people, they have increases in pain as a result of overdoing physical tolerances or as a result of kind of neuropathic variations in the experience of pain. People with chronic pain invariably have episodes of increased pain, which are part of a sort of chronic picture of stress. Treatments in themselves can be painful and unpleasant, and then there's a whole lot of associated losses, as you saw in the slide earlier on, mapping out when chronic pain becomes a problem, which can be part of this chronic adversity picture. So chronic pain and resilience, where these two intersect, is I think on the whole much more around this chronic adversity picture rather than the single incident one-off stuff. Chronic pain is not really something that one bounces back from because it doesn't go away. It's there all the time. It's more the picture of managing ongoing adversity, which is where resilience comes into the chronic pain story. So if we have a look at some of the research that's looked at resilience and chronic pain and gives a bit of a feel for what, in this case, people with pain understand by the term of resilience. I think it's quite interesting. It's a qualitative study, again, an Australian study actually, this one, looking at asking people with pain, with chronic pain, what does resilience mean to them? And so there's kind of general themes here of resilience is something around recognizing individual strengths. So that speaks to the slide I had earlier on, looking at self-esteem and looking at optimism. So individual strengths around not giving in, developing a tolerance, understanding how to manage your pain relates to that coping strategies idea, which is again an important part of resilience, and then using your previous experience to feel good about how you're managing the pain in the present, which is really that self-esteem issue. Certainly resilience has some association with accepting the pain, so that you can move forward in time rather than feeling like your life is on hold whilst you wait for the pain to be fixed or resolved or to go away in some sort of way. Looking for the positives in life is the optimism component of that resilience picture. And then learning to accept help is the social support part of that the resilience component slide I showed you earlier on. Taking strength from partners and friends, being able to ask for help. Resilience isn't some concept of standing alone, isolated, against all odds. It is about drawing on your network and having a network around you to assist. It's interesting if just briefly look at the research on this, at how we might measure resilience. And this is one of the resilience scales that are used, and it was used in the study I'm about to show you briefly coming up. So effectively we're asking people to rate themselves in terms of how much they agree or disagree on a number of statements here around how they deal with stressful events or hard times. So you can see it taps into things like bouncing back, recovery, how long it takes to get over setbacks and so on. So just to give you a sense of resilience is measured this way, and there are certainly debates in the literature about how well we are tapping into this concept with self-report questionnaires that we typically use in this area, and I'll just refer to that in a sec. So a study that I published last year looking at resilience and adjustment. Again, this is a fairly new area for chronic pain. It's been, as I said, in other literatures, developmental literatures and trauma literatures, but chronic pain much more recently. So we were interested in the basic question of, does resilience firstly have the expected associations with good adjustment to chronic pain? So if there's some value in looking at resilience as a concept with pain, it should map onto some of the other concepts that we look at in chronic pain for good adjustment. But secondly, we're interested in seeing whether does it add something to our understanding of chronic pain. So as resilience as a concept, does it give us a further insight into what makes people with pain adjusting well versus the excessive suffering kind of idea that I talked about earlier on. So that were where we started with this research. In terms of the first question, yes, greater resilience was associated with those other variables in pain that we look at in terms of understanding good adjustment. So folks who describe themselves as more resilient also had less disability in relation to pain, they were less fearful of their pain, and actually they reported less pain intensity overall as well. So resilience in that sense was as we'd expected it to show in terms of the associations with other chronic pain variables. Importantly, for the theory of this, the participants who reported greater resilience also reported actually a greater number of social supports. We asked them about how many people do you see and how supportive are they, and the more resilient people reported having more social support, which is a very important fact, but also they were more likely to still be at work, either full-time or part-time. So again, I think the notion that supporting work engagement as a therapy, if you like, as a therapeutic activity for most people is a really important concept in pain management. But somewhat disappointingly for us, resilience didn't add anything to the standard predictors that we had of who makes a good adjustment to chronic pain and who doesn't. So things like how you think about your pain, how confident you are to manage pain, how much fear of pain you have, those are the typical things that we know do predict good adjustment, but we were actually hoping that resilience might tell us something more about people who live well despite pain, but unfortunately in our study it didn't. It didn't add anything to the prediction. Now that doesn't say to me necessarily that it's not a valuable concept. I think what it said to me actually was that we're not measuring it particularly well, and that it's not something that is quite as straightforward in terms of how you capture it as the typical self-report questionnaires use, and that possibly in chronic pain in that area we need to look at some possibly more sophisticated ways of understanding how to measure resilience. So just to finish up, folks, basic conclusions from this area. The really good news, if you like, really positive news, is that general terms adults really do show high resilience. So we can have some very upsetting, very distressing, very highly stressful events happen, and the vast majority of us are going to bounce back very well and not show any great disruption to normal functioning, which is tremendous. When those stresses are not one-off, but when they are ongoing, unending adversities, and particularly when they're not just at the personal level, but at a sort of societal, communal level, the picture isn't so positive, and about 25% are not going to show the sort of resilience that we've been talking about. Chronic pain is certainly a stressor which will test resilience, not just in terms of how you cope with that initial injury, but I think more importantly really it's the ongoing experience of pain. The fact that with chronic pain it's a chronically adverse experience, and despite best efforts to get it resolved, chronic pain by definition is the one that goes on and on and on, and so that can be a very significant test of resilience, I think, as a chronic stressor. But the evidence is that chronic pain patients do show resilience, and on the whole, the vast majority of people do manage to maintain normal levels of functioning despite, or relatively normal levels, somewhat modified, often somewhat reconstructed, but there's a demonstration of good adjustment on the whole, and it's stronger for people with stronger social networks. And so that's something I think, as our society perhaps gets a little more fragmented with electronic forms of social connection, we may need to look at this a little bit more clearly down the track. But the point I'm trying to make is too that resilience is a result of multiple different factors, and while some people do seem to naturally demonstrate resilience, I do think there are also factors that we can actively target and foster in people who don't make an immediate positive response to a stressor, and we can foster resilience given opportunity to target those 4 different areas that I mentioned earlier on. So I do think it's something that we can be optimistic about in being able to facilitate people's resilience if it doesn't happen of its own accord. So thank you very much for your attention, and if there's any questions, happy to respond.
Wonderful. Thank you very much. That was a very good presentation. A couple of questions. So one person was asking about some advice or thoughts when the situation is that they're on disability and have to prove that they're sick, but at the same time, how do you balance that with then being resilient and functioning normally? And that kind of catch-22 that can be involved there.
Yeah, that's a very good question, and unfortunately a very common question. I think it's exactly the same dilemma that people in Australia have. I think it's the intrinsic problem with the system, which looks for or sort of sees things in very black and white terms, and of course something like chronic pain is not at all black and white. I suppose in a broad sense, resilience is something around maintaining your mood, your optimism, your capacity to engage with other people, to laugh, to smile, to not have the stress or take over entirely your normal functioning. And there's that part of one's life in relation to one's friends and family, and people are important. In relation to interactions with disability schemes and governmental schemes which want to partition people into this lot are sick, this lot are not sick, this lot are disabled, this lot are not disabled, where there's no shade of grey or there's no sort of individual variation, it's extremely difficult, and possibly the resilience there is something to do with being able to keep your chin up despite being in a system which sees things in usually pretty black and white and artificial kind of terms. The resilience there is possibly something around staying positive and staying optimistic, even given the fact that the system is almost working against that in some sort of way.
Very good. And what does successful resiliency-based treatment look like?
I think that sort of treatment will look like moving back to that slide earlier on, where we have those 4 components. So we have specific targeting of self-esteem, self-worth, self-value. We have specific targeting of optimism, and looking at these would be in the cognitive therapy, typically, in sort of cognitive therapy domain of looking at how we think, how we interpret, how we appraise, not just what's happening to us, but the world around us and the future. It will be targeting coping skills training. We'll be looking very specifically at what is the best evidence base for when you live with pain every day, what are the most useful things you can do, and what is not helpful for you to do from an evidence-based perspective. And then we'll also look finally at supporting and encouraging and fostering people's social engagement. I think one of the really tricky dilemmas of chronic pain is that for most people, moving about is uncomfortable, and in order to connect with other people, by and large, you need to move about. So people do become often quite socially isolated and quite lose connections with work colleagues or people from the sporting club or the church or whatever it happens to be, not because they want to, but because it's uncomfortable and difficult to maintain those connections. But there's really significant evidence in lots of, not just the resilience area, but other areas as well, where by losing those connections, you lose a whole lot more as well. So something around resilience intervention would be looking at whatever means it can be to maintain and foster people's social connectedness as well.
All right, and then someone else asked, and it's a little bit related to that question. Mm-hmm. Can the brain be trained to ameliorate some effects of persistent pain by dwelling on the positive, i.e. counting your blessings instead of dwelling on negative effects of pain?
Well, yeah. In broad terms, yes, there is quite good evidence now that brains are these somewhat plastic structures, and when chronic pain becomes a problem, it's partly because of that plasticity taking hold, but it is also, there's good evidence that psychological treatments do have an impact on brain architecture and brain structure as well. So it's something I'm sure we're going to see more of over the coming years. But yes, people who have a good response to pain management programs or cognitive behavioral treatments for pain, or some of the newer mindfulness and acceptance-based treatments, we don't scan their brains routinely, but the research such as this shows that there is a change back towards basically increasing that descending inhibitory system that I spoke about earlier on. The pain is still there, and people, when they have good outcomes from pain treatments, will still say, yes, I do have pain. It hasn't gone. It's not a miracle cure. I still have pain, but it doesn't bother me so much. And it's that change in bothersomeness which is probably reflecting some change in brain structure or connectivity or chemistry. So that effectively the brain learns to pay less of a priority to that pain information and to start reprioritizing other things. But that, of course, is extremely difficult to do when pain is, we are wired so that if we have pain, it takes priority over everything else. So it's a very difficult thing to do, but it does seem to be what happens. Yeah.
So thank you very much, Toby, for the presentation and for your knowledge and insight on this topic. I think it was really great.
It's my pleasure. I'm very pleased to speak with you this afternoon for you, this morning for me.
Wonderful.